We're an organization, a statewide organization based in Boston that works to promote strong public health policy here in the state, both working with the legislative and executive branches, as well as with local coalitions and partners. So Daisy has put up the webinar objectives today, which include recognizing the role of some core public health frameworks, discussing the value of collaboration between different sectors, and defining health equity and discussing some of the applications. Okay, so the first thing we're going to do is just ask you all a question. If you can tell us what topic or topics does your coalition or project focus on? And there's 4 options here, or other. And you can also, if you work on other things, you can type those also into the question box so we can see. We just want to get a little sense of who's on the line and what kind of things you all work on before we dive in.
Thank you all for giving us your answers. Keep clicking away. We see people are a little spread. We'll share the results in a bit to show you where you all focus on. And if you are selecting other, feel free to type in your area of focus in the questions box so we can get an idea. So far we see cancer prevention and genetics. We have a professor from a university. Give you a couple more seconds to fill out the poll before we close it.
Okay. All right, so I think we're going to put up the results so everyone can see that on your screen. So we have a nice mix. A lot of people work on healthy eating, active living, substance abuse, violence prevention, and also quite a few others. So thanks for folks who are typing in other, and I think everyone can see those. Can everyone see the question box that lists what folks work on? So a lot of different things here. My presentation, since this is sort of a Public Health 101, is going to focus really on the basics of what is public health, how is it similar and different than medicine, how are we doing as a state, and what are some of the methods by which we can work to improve health outcomes. So I like to start at the beginning when I talk about what is public health. And this on the left is a map of London in 1854. And there was an outbreak of cholera in London in this neighborhood. And as you might imagine, the medical science and public health science of the day was not particularly advanced. But the medical professionals, the physicians, the nurses of the day did their best to treat the individuals and the families and a lot of children who were suffering and who were dying as a result of this cholera outbreak. Part of the problem was they didn't know what caused cholera, so they didn't really know how to treat it, but they did their best using the tools of the time to treat those individuals. There was a gentleman named John Snow who made this map on the left here, and he mapped out where people lived who contracted cholera. And he mapped that in relation to where people got their water. And he went out with some good old-fashioned shoe leather and interviewed families about where they got their water, because of course there wasn't indoor plumbing at the time. And he came to the conclusion that this pump, which is on the right on Broad Street, was contaminated with something that was causing cholera. They didn't know cholera was a bacteria at the time, but he came up with this theory. They took the handle off this pump, and the epidemic subsided. And this really was the beginning of sort of the modern era of basic public health science, of basic public health epidemiology. And I like it because it illustrates a really nice point about the difference between public health and medicine. His focus was on the populations, the people who lived in that neighborhood, looking at the neighborhood as a whole. When that intervention occurred, when that pump handle was taken off, that impacted the whole neighborhood. And that's different than the medical approach to the people who were becoming sick, which was to look at individuals and try to treat their illness. So the focus in public health there and in our work today continues to be on the prevention of disease and injury and on health promotion as opposed to the treatment of individuals. This sort of epidemiological study, community input, community engagement is the way that we quote-unquote diagnose things in public health as opposed to the traditional physical exams and tests that we're all used to in our physician's office. And the treatment is also different. In public health, we're working to change environments where people live, work, play, improve living conditions, educate people, as opposed to things like medication, surgery, therapy. Our workforce in public health is also very diverse, and even though I think some people on this webinar probably don't consider themselves to be in public health, I would argue that if you're on this webinar, you're in public health, and I think what that speaks to is our professions are very diverse. Medical professions tend to be more standardized, specific credentials, specific training, and so forth. Now, this is not to say that public health is better or worse than medicine, but it's to say that it is different, and these are complementary approaches to improve health. I know I certainly want, when I am sick or my kids are sick, I want them to have the best medicine available, but I also want to make sure we live in a neighborhood that the conditions promote good health before we need that medical care. So these are some of the 20th century's greatest public health achievements. And in many of these, probably not much of a role for the medical system, but vaccines have prolonged life tremendously. Motor vehicle safety, it's in many people's lifetimes. They can remember seatbelts were not in common use. It seems hard to imagine today, and so forth. I won't go through these all because I know you can read them, but these are some of the achievements we made during the 20th century. And so what has this led to? It's funny, we're sitting here in Boston, sort of a hub of advanced medical care that we're all very proud of. But the advances in life expectancy since 1900, due to that tremendous medical care, are pretty modest, estimated about 5 years, whereas the increased years of life due to public health measures, 25 full years. So we are living a lot longer, healthier lives because of those victories that we mentioned. So what's the public health system? And there's a couple entities that we think of traditionally as the public health system. One, of course, is our Department of Public Health, our State Department of Public Health. And some of these numbers are a little bit outdated, so don't quote these, but this is more to just give you a flavor. And because we focus so much on the state level, I've really looked at state funding and state programs. There is other federal funding that comes into our Department of Public Health. But we have about $515 million in state funding of the Department of Public Health. That's divided between, upwards of 70 different line items in the state budget for a variety of categorical programs. About 2/3, a little less than 2/3 of those are community-based programs. That's a percentage of the total funding. And the others are public health hospitals. We've had huge cuts since the recession that started back in FY09, more than $50 million. So these things have really suffered. The funding at DPH, I tend to think of it in 3 categories. One is sort of the big programs, and about 3/4 of the funding goes for 5 big areas: substance abuse, WIC, early intervention, HIV/AIDS, and the public health hospitals. And then there's 2 other categories that are funded at lower amounts. One is sort of your traditional primary prevention programs: smoking prevention, cessation, youth violence prevention, school health services, mass in motion. And then there's a category of infrastructure funding, or what we think of as infrastructure: communicable disease control, food protection, inspection of healthcare facilities, etc. And one of the challenges we all face in public health when it comes to funding is that public health funding is often the first cut and the last restored when budgets get tight. And it's sort of our charge to try to reverse that as we look ahead. So that's at the state level. But of course in Massachusetts we have a local health system as well. We have 351 cities and towns. Each of them has a local board of health. This is different than in most other states of the country where they organize public health at the county level. And there's some positive, aspects to that, and there's some challenges as well. Our local boards of health have a tremendously long list of statutory responsibilities, some of which are listed here, such as enforcing the housing code, inspecting restaurants, responding to communicable disease threats, like children's recreational camps, things that most people don't really think too much about. They just assume somebody's taking care of this, that if you send your kid to a camp, that it's a safe place. You don't really know who inspected it, when it was last inspected. You just assume that's happening. You don't know what level of state government did it. But local health is responsible for a lot of these things. Problem is that close to two-thirds or close to three-quarters of our municipalities have inadequate staff to meet these responsibilities. If you think of our municipalities, we have a couple of big ones, Boston, Worcester, Springfield, are bigger cities, but a lot of our municipalities are communities of, 3,000, 5,000, 10,000, and they don't have the same kind of infrastructure to do these things. So unfortunately, we have a situation where it's a little bit of a roll of the dice depending on where you live, the level of public health services that you might have available at the local level. But that is not really the public health system, or at least the extent of the public health system. This diagram is a little bit more accurate in terms of what the public health system really is. And this is where I think probably a lot of you on this webinar fit into one of these categories here, or something. If the kind of organization you work for isn't here, it probably could be up here as part of the public health system. Because this web of services, this web of protections, this web of interventions, really collectively is what represents our ability to achieve our public health goals. So with that, let's ask, given this, we have this system in place, or these various systems, how are we doing? And, as a state, we're doing pretty darn good, actually. And a lot of these outcomes were ranked in the top 1, 2, 3, 4 among states. Even those that are at the bottom of this list, we rank in the top 4th or 5th of states. So there's some room for improvement, but, we're doing pretty good. For instance, we have the lowest infant mortality rate in the country. That's something we should be really proud of. But unfortunately, when we dig into these numbers, it's not quite as rosy as it might seem on the surface. For instance, Black residents are 55% more likely to suffer from infant mortality compared to the state average. And that's a pretty big problem that you can't see when you just look at the state numbers. We have the 3rd lowest obesity rate in the country. Pretty good, except if you're Latino, where you're 31% more likely to be obese. Similarly, diabetes, room for improvement at 11, but not too bad. Low-income families twice as likely to have diabetes as the state average. Smoking is very similar in that sort of top quarter. Low-income residents 60% more likely to smoke compared to the state average. So we've got some real inequities here that we have to figure out how to deal with, even in a relatively affluent state that has very good aggregate numbers. So when we talk about health inequities, we like to differentiate health disparities and health inequities, because disparities is really just a difference. And there's many differences we observe, such as the fact that male babies are generally born heavier than female babies. That's not really a problem we probably need to be too concerned about. Inequities, when we use that term, it really refers to outcomes that are preventable or unfair or unjust, things that we want to change. I know there's a question about the data, and I'm happy to share the data sources for all of the data on this slide with folks afterwards. So let's see, we're going to keep going this way. So this is just an example. This is in Roxbury and the South End in Boston, if folks know Boston neighborhoods. This census tract here toward the bottom of the slide is sort of going from lower Roxbury up toward Dudley Square. And you'll see the life expectancy there is a shy under 60 years. Whereas right down the street, as you get a little farther into the South End, life expectancy is over 84 years. And this is a really shocking inequity in people who literally live down the street from one another. And you can see, you'll probably not be too surprised to see that the lower life expectancy census tract has about 32% of white residents compared to about 62 in the higher life expectancy census tract, and similarly with poverty. So this is a diagram that really looks at what are the social determinants of health? What are the things that actually impact our health outcomes? And most people in the general population really first think about healthcare. But this shows us that healthcare, represents maybe about 20% of our health outcomes in comparison to our physical environment, socioeconomic factors, and health behaviors, which represent a full 80% of our health outcomes. And there's a couple different versions of this you may see. They all vary a little bit depending on the categories and the percentages, but they all tell pretty much the same story. So you know, a rational person would think 80% of our health outcomes not healthcare related. You know, we probably have roughly 80% of our dollars going to those things, right? That would just be rational. But of course, the exact opposite is the case. We have the vast majority of our resources going to our clinical care, access to healthcare services, medical services, and far, far less resources going into those other buckets that we know have the broadest impact on health outcomes. So we look at things like this list when we think about social determinants of health: income, income inequality, education, racism and other forms of discrimination, early childhood experiences. These are things that really have the biggest impact on health outcomes. And I'm guessing there's a lot of people on this webinar who work on one of these issues who, you know, might not think of yourself as a public health practitioner. But I would say if you work on any of the issues here or any other things that might not have made it onto the slide, you in fact are a public health practitioner because you're improving the health outcomes of children and families here in Massachusetts or elsewhere in the country. And I really do like to say that public health or health more generally is not a sector. Health is an outcome. Health is the thing we want to get at the end of the day. And whether you have a public health degree, a medical degree, or work in community development or some other field, if you're helping us get to that health outcome, we really are partners together. We really can't underestimate the impact of racism on inequitable health outcomes. So I just have a couple stats here. Almost 100,000 black folks die prematurely each year that would not die prematurely if we didn't have these racial health inequities. That's a whole lot of people that we should all take as a top priority. And we know that racism impacts all kinds of structures that impact people's lives: transportation, housing, education, all of those social determinants of health. And racism impacts health through those institutions, but there's really good data and a growing body of evidence that racism impacts health actually in the physical body through allostatic load and the impact of ongoing stress on people's biological systems. And this is true across socioeconomic status. When socioeconomic status is controlled, people of color do worse on health outcomes compared to their peers of the same socioeconomic status. So this is a diagram that I really like that comes out of King County in Seattle, Washington, that looks on the left at some of these really sort of fundamental factors that impact health. In the middle here, look at both systems at the top and also outcomes that could be measured in terms of the institutions that impact health, whether it's food security, graduation, incarceration, etc. And then on the right, look at the actual outcomes we want. And I think these things in the middle are really helpful, not only because this is, I think, just a nice visual, but also it tells us things that we can actually measure to know whether we're sort of making progress on the things that we want to do. This, folks hopefully have seen, this is the health impact period. It was developed by Tom Frieden, who runs the Centers for Disease Control. And I know Barry's going to talk a little bit more about this, so I'm just going to mention it briefly. It looks at the factors that have the biggest impact on health, those things at the bottom, and then the smallest impact on population health. And it's those socioeconomic status factors, it's those environmental factors that impact people's daily lives that have the biggest impact on health. And it's the things at the top that generally impact individuals more that have the smallest impact. And I should clarify, when I say health here, we're really talking about population health. We're really talking about the impact on groups of people. To say that when any of us are sick or families are sick, we want those services at the tip that are going to impact us individually or our loved ones. But even if you don't care about all of that, and even if you don't care about the inequities and the social justice issues, or even if some of the people we work with don't, we're losing a whole lot of money because of preventable chronic diseases. And this is just some estimates just for the state of Massachusetts: $3.5 billion on direct healthcare spending. And if you translate that into productivity, missed days of work, you're talking in the tens of billions of dollars in lost productivity. So this is really dragging down our economy in addition to sort of insulting our basic sense of fairness and justice. These are just a couple of more specific examples about how a couple of different social determinants of health actually impact health. And again, I know Barry and Keir are going to talk about some of these more. But we know that access to affordable public transportation, for instance, actually can reduce emissions and improve health outcomes related to respiratory conditions like asthma, which, by the way, impact low-income kids in urban areas more than anybody else. We know that access to quality, affordable housing reduces stress, improves mental health outcomes, reduces health risks that are directly related to housing, like lead poisoning, and also does things like increases the ability of survivors of domestic violence to escape and get to safety. Some folks may recall last year in Massachusetts there was a campaign and a victory on increasing the state earned income tax credit. Of course, that's good to have more money in people's pockets. There's very good data that show that people who receive the earned income tax credit are more likely to receive prenatal care, more likely to buy healthy foods, and less likely to smoke. So there's some really direct health outcomes related to these kind of social determinants that many people would not automatically associate with health. So this is all well and good that we know these things, but if we're going to change this, we really have to take action, both at the local level in our communities, at the state, at the federal level. At MPHA, we focus a lot on policy change because we know it's policies that impact a lot of these social determinants of health. So this just real quickly, so you know a little bit about who we are. This is sort of our program model. We work with a lot of local partners. We convene partners. We work with local partners to identify issues that are impacting their neighborhoods, and we work to build capacity with our partners to be effective advocates. Because we believe if all of us are more effective advocates, we're going to be able to create the change that we need. It can't just be one of us that does it. It can't just be one or two organizations. It can't just be people in Boston. It has to be all of us working, sort of pulling in the same direction. And when we have powerful advocates, we can create the state and local policy change that flips both perhaps the resource allocation on its head to invest more in those upstream factors, but also addresses the particular institutional barriers in housing or transportation or other institutions. And then ultimately what we want is healthy communities and health equity. So the way we're doing this, I'm not going to read through this, but you can see these categories on the left here. These are the 5 categories that we're going to be focused on in the coming years. These are our focus areas for 2017 and 2018. So this doesn't cover everything. Public health is too broad for any one organization to cover all the topics. So if you're wondering why isn't some issue on here, you know, it's not because it's not important. It's because we've tried our best to sort of focus in on areas we can have impact. But we try to have a broad sort of breadth of reach as well. So that'll just give you a little sense of how we're thinking about impacting this space. And if you're working in one of these areas and want to be involved in policy change efforts, we'd love to hear from you about what's going on in your community, and we'd love to collaborate with you. So I'm going to just put up one more slide here. I'd like to invite you to our annual meeting, which is coming up on November 16th in Worcester at the DCU Center. Our theme is focused on moving the public health agenda by combating racial justice, both in the work we do in communities, but also in terms of operationalizing those principles within our organizations. We'll have some great sort of high-profile speakers. We're also going to have breakout sessions on each of those 5 issues where folks can really dig in and understand the policy landscape and help us figure out where we can have the greatest impact within each of those categories. So with that, I'm going to make sure people have my contact info. And if there are questions that are coming in, we're happy to take those. And otherwise, I think we'll keep the show moving. So thanks so much again for being with us today.
Thank you so much, Maddie. And we're going to keep moving this train along with all this wonderful information. We are sharing and learning. So thank you all. I'm going to queue up our next presenter, Barry Keppert, and he's going to take it away.
Thanks, Daisy. It's really great to be with you all and to be with Maddie and Kia and everybody here in the room. So thanks for joining us. So I'm going to talk a little bit, building off of Maddie's presentation, of what it's like to kind of build some of these considerations into our communities. And I'm coming from a regional planning agency, so we serve 101 cities and towns around Metro Boston. So I'll give you an idea of what we're doing at both the state, regional, but then also at the local level with partners that we have on the ground. Before we go to the next slide, I was going to ask everybody on the line just to close your eyes for a second. So give everybody a second, close your eyes. Now I want you to open your eye real quick and look at those photos. And after everything we just talked about, when you think about health, which of those do you look at first? Which of those do you think about first as a thing that's really driving the health of our communities? And so I'm coming back again to that graphic that Maddie shared. When we start looking and thinking about what are those things that determine our health and the health of a population, of a community, we begin to see those things that we may not think about, things like healthcare, maybe what we're born with, as really being as significant as it seems to be a lot of other factors do in terms of what kind of health we have. And also in this, even though they separate 3 bars here, in many ways they all influence one another. So as Maddie mentioned, where you're born and what you're born into can have an impact on how your genes express themselves. And so a lot of these factors interplay, but we know what's around us and what we're being born into has a significant effect. So if we take those premises and you accept those, as I do and I think some of us here in the room do, I think it's fair to say that our neighborhoods should not be hazardous to our health. Where we're living, where we're being born, where we're working should not essentially be causing hazard to our lives. And just to put it in the context, what other ways in your life do you accept hazards? Do you accept hazardous foods? Do you accept that if you are to take a trip on a plane, that plane is going to crash? You don't really accept those hazards. You want to know that where you are is safe and it's providing good things. But it seems like when it comes to health, we're willing to accept this in our neighborhoods. And so how can we go about changing that if we buy that premise that where we live and where we work shouldn't be hazardous to our health? Well, as Maddie presented, here's the health impact pyramid, and on the right side, hopefully on your screen, you can see a lot of what are those traditional ways to get at public health, from the individual level at the top of the pyramid to the population level at the bottom of the pyramid. And so when we start thinking about how we can make large groups of people potentially healthier and have more well-being in their lives, because again, we're defining healthier not just as the absence of illness, but essentially social, mental, and physical well-being. How can we really move large groups of people? And so public health really to some degree has control over a number of these factors, but it doesn't have a control over all those things when we talk about environmental, social, behavioral conditions. If you go to the left side of the pyramid, we're giving you some idea of what other sectors can begin to influence. In particular, I'm coming from the planning sector, but you begin to see there's a lot of other sectors and topic areas that can influence at a population level how people can be more healthy. So what I'm going to do next is make a couple statements. I want to see if you agree with them, and then I'm going to make a case for them as we think about what public health is and how it impacts and involves other sectors. First, I'll read this one, but in kind of subsequent similar slides, I won't read them. But slower vehicle speeds make people feel safe and encourage them to be active and walk and bike more. For example, we know that if you're hit by a car going 25 miles per hour, you have a less than 1 in 10 chance of being killed. At 40 miles per hour, you have a nearly 7 in 10 chance of being killed. It's not right that residents of certain neighborhoods have to experience speeding vehicles and be at a greater risk for severe injury and death, while others do not. To change this, officials, planners, and public health professionals use community strategies like traffic calming and slower speed limits to reduce speeding. So one of the projects MAPC had the chance to work on with a number of partners was to look at this policy proposal at the state level that said on local roads, so if you think about probably the street that you live on, the residential street, those streets that don't have speed limits, if we were to change that speed limit from 30 miles an hour to 25 miles an hour, what kind of impacts might it have? And so what you see in front of us is what we use in a pathway diagram as part of a health impact assessment, which is a way of, again, thinking about decisions that may not be considering health, can consider health. We began to link what lower speed limits could mean, both in the near term, almost immediately, would it have an impact on things such as collision severity, how much somebody could be injured in a crash? Ultimately, to getting to overall what injuries would people be experiencing, and what changes we might even see in things such as chronic disease, like physical activity, or essentially respiratory issues that people might have. And so we did this health impact assessment with a number of partners and using a really good model from our metropolitan planning organization. And we were able to quantify some of those things, or at least make an estimate that if you were to limit that speed limit from 30 down to 25 miles an hour, what might some of those impacts can be? And we looked at this again in a way that we could be as neutral as possible. On the left, you can see the positive impacts. Fewer crashes, fewer people dying, fewer people having to experience injuries as a result of crashes, and then also savings you could get from that. On the right side, obviously there would be some consequences if we slow down traffic. But if we think about them in terms of people's lives and what's happening, there is something that often doesn't get quite considered. Maybe those negative impacts get considered on a slower speed limit, but a lot of those benefits may not get considered when we think about how this impacts our neighborhoods. A piece of work that we're just starting, but others in the Commonwealth have been working on, is the idea of Vision Zero. What if we set as a goal that in our transportation system, that there should be nobody who dies and nobody who's severely injured as a result of the transportation system? What does that actually mean when we start thinking about traffic that way and bringing a public health perspective to transportation? Thinking about how do we start from kind of the pedestrian user, someone who could be very, very vulnerable, but going all the way down to the car. And if you look at that, the quote on the left, it talks a little bit about what if we were to think about how a crash, how someone's speed could actually result in someone's death or severe injury. What if we were to use that as a frame? And so now we're really excited to be working on this project and thinking about how can you, not only in places like Boston and Cambridge, which have Vision Zero approaches, begin to think about how do you spread that out to smaller cities and towns and make it a tool that's available to neighborhoods across the Commonwealth. So what does this mean in your work, and how can you think about that? So one of the perspectives that we use in our work is what we call policy systems and environmental change. And so you'll see here some examples of what you could do in your own locality, within your own coalition, to make some of these changes. You could push for a change in policy, adopting slow zones, that people have to go slower in particular areas. You could actually work with your local engineering officials to see if you could reduce design speeds. And lastly, you could actually get out into the community in a physical way, make changes such as traffic calming changes, which alter kind of the speed vehicles can travel, accommodations for bicycle and pedestrians, but that can also affect volumes of how much traffic goes down certain roads. So those are just three things that you can think about and what you could do to address public health in this frame of transportation. Here's another statement. I'll give you a moment to read this. So it's clear, hopefully, from that housing insecurity is a real issue. And specifically when it comes to children, it sets them on a trajectory that puts them at a disadvantage. To Maddie's point earlier, in terms of what is an inequity. People who are living in these conditions, children especially, are not given the same start that other children get who live in secure and stable housing. We've been trying to recognize this piece, and this is a nod to Dr. Megan Sandell and others at Children's Health Watch, is that looking at housing as a vital sign. What if housing is actually a prescription for making people feel better and be more well? And so what we've done is begin to think about issues related to the quality of housing, the affordability of housing, and essentially the location of housing. And what if we bring those three factors into how we go about planning for housing in our communities? If you're not familiar with it, in a number of cities and towns, especially those that may not have enough subsidized affordable housing, they often engage in something that's called a housing production plan. And what they do in that is they look at what is their existing housing stock, how is it being kept up. To Maddie's point, do we have a lot of older housing where people might essentially be exposed to lead, might be exposed to something hazardous in their housing? But in the same way, how do you think about going forward? There's a need for more housing, and especially in the Metro Boston region, I think across most of Massachusetts, there's a need for more housing, especially affordable housing. And so what we've begun to do, and we've had a couple chances now with towns I've been able to partner with, to look at how can we build that into the housing production plan? How can we build a little bit more into thinking about it's not just a physical thing, it's not just a housing unit, but the purpose of having that housing is so that people can have a place that they can live and get access. It's a place where people can live and feel that they're safe and that they don't have to worry about, and if you have children or family members, maybe an older adult, don't have to worry about them when they're inside the house because you know that they're safe and they can access that house and they're not going to be exposed to something that's going to cause them harm. But then also you create that where it's a very stable place, and so meant for someone's mental health, someone's ability to think about what they need to do in their job, to think about how they might be helping a neighbor. Their thoughts aren't being occupied all the time about, am I going to be able to stay in the place that I am? Am I going to be able to afford the rent the next month? Creating some more of that stability and thinking about ultimately how that might deliver back into our into the health of our community. Another way we've been thinking about it, and this is with partners at the Conservation Law Foundation and Massachusetts Housing Investment Corporation, is this idea of the Healthy Neighborhood Equity Fund. So this is a fund that exists now, but right before it started, we had the opportunity to do a health impact assessment with them. And we ended up looking at 12 different dimensions of if you were to build a new neighborhood or revitalize a neighborhood around a transit location, like where you have a number of bus stops or where you might have train or subway access, what are some ways to think about how a private investment fund could affect that place and actually provide a health return in addition to financial returns. And so one of the things we wanted to be really clear of in looking at that is that if you make a place like that more attractive, you actually run into issues of people being displaced. That community that you're trying to value in that place, whether they have social connections, whether they use it as a place to access green space, good schools, get to know their neighbors, that place becomes more attractive. You can run into that issue of those people no longer being able to live there. And so if any of you are from the Metro Boston region and potentially outside, you know that's a real force in the neighborhoods here. And so how do we begin how an investment fund that will be supporting that new development or redevelopment can actually support and help people stay in that particular area? And so in this particular HIA, we're able to look at what is the risk of gentrification leading to displacement. Because gentrification on its own may have some positive places. I think most neighborhoods would like to know that they have the resources to keep up the neighborhood. But we don't want those people who live there to be displaced unless they want to move somewhere else, not because they have to. So again, understanding that housing might be a vital sign. What are some of the things that you can do in your own community, thinking about public health from a broader perspective? Well, you can do something like adopt inclusionary housing, saying as new housing is developed or redeveloped, can we include a certain part of it that has to be affordable, has to meet certain requirements so we can accommodate people of all different income levels within our community. Just like I showed you earlier, you can think about if your town's doing a housing production plan, can you bring health into that conversation more than there is now? Another tool that we've also looked at, and this is at MAPC, is an approach we call managing neighborhood change. Understanding that neighborhoods are going to change, but how do we do that in a manner where we're not displacing the population, the people that are there now? And then lastly, environmental change. Are there ways that we can bring in community members, banks, other organizations like foundations that may be able to provide more resources to help us kind of keep things affordable longer or increase affordable housing choices in our communities? And this is the third statement that I'm going to throw your way. And as you read this, it might seem to you maybe it's a little bit softer. It's not a physical place like a house. It's not a street. But we do know the more people are engaged in their community and more people feel like they're the ones that are affecting the change in their community, the more they're built in and actually the healthier people are overall. That not only is just a process, like a public process point, but it's a point where we understand that for the long term that's affecting people's health. So one of the approaches we've been using in our work is following an approach called photo voice, which is essentially taking a camera and putting it in the hands, typically any youth, but typically it could be anybody in a community, to have people go out into the community and ask questions about what are those things in your neighborhood, what are those things in your city or town that are keeping you healthy or that are making you unhealthy? And how can you use that to kind of really promote a critical dialogue to getting into it? One of my favorite parts, and people may use this in other parts of their work, is essentially the 5 whys approach. Not just accepting that first issue of, well, I don't like this place because it's littered. Well, why is it littered? Using that as several levels to get deeper into why those things might exist in that place and thinking about that way. We've also used this tool as a very effective way, especially when used with youth, to get to decision makers in a way that's real and very, very tangible. Here's a quick example from back in 2012 when you had the opportunity to do this in the city of Somerville. A picture that had been taken and a narrative that a young person there had identified why she had taken that picture. One of the great things about this particular instance is that after doing that, like I said, reaching out to decision makers, we were able to use that perspective, that photo, that voice to essentially precipitate and make some change in that neighborhood. And begin to think again, if you look at those two situations, if you live there, what does that tell you about your neighborhood? What does that tell you about what you're able to affect? And thinking about, again, what that has in terms of a public health perspective. We didn't want to just stop right there with some of our work, so then we ended up beginning to blend it with this approach called placemaking. And in particular, the way we think about it in terms of sometimes called tactical urbanism. How do you get in there with things that you can do really lightly, cheaply, but things even that could potentially be picked up as things that change to demonstrate what could happen to that place. We had the opportunity almost about a year ago to do this in East Boston. I'm working with youth and residents. We had a conversation about what do you think keeps you healthy or keeps you unhealthy in this neighborhood. And one of the things that got clearly identified is there's these huge intersections at a couple places where just lots of asphalt. People park illegally. It doesn't get really used in any way other than for vehicles. And so we had the opportunity one night to go out there. We laid down cones, laid out a new kind of extension of where the sidewalk was and where it ended. We timed it along with a festival called the Dia del Maíz. It's a festival from South America, Central America, and we got to celebrate out there. And so on the left, you saw essentially we created that space in a fantastic way. We put some chalk out there, and all of a sudden kids were out there drawing things in the street. They were taking advantage of that space where typically we would just have cars parking there. So we tested that idea and we showed it based upon what had been identified. And on the right, we got the chance to kind of connect it with the local kind of festival-driven food. And so there was a kind of a corn soup that we had also. It was great. It was a cold night, so it was actually fantastic. So what can you do around photo voice and placemaking? Well, there's ways you can work with your community to talk about maybe this will make this as part of our typical public engagement work. We'll train the staff that we work with in our city or town about how to use this and techniques like photo voice. But then you can also create almost like a lending library for your community. All it takes are some cones, maybe some spray chalk, just to make available so people can go out and test this on their own, show that they can actually change their neighborhoods. Back to a point I think Maddie hit home on too. I think it's really, there is this difference between equality and equity. Equality may give everybody the same foundation, but we know everybody is not started in the same place. We know everybody's neighborhoods are not the same. So how do we begin to think about this in a way that we're addressing those inequities so that we don't have the disparities that we exist, that we get to see everybody in our neighborhood, in our society, achieve those outcomes that they can achieve. So I started out with that premise that neighborhoods should not be hazardous to our health. Well, I'm also going to go with the other premise too, that health starts long before illness. It starts in our homes, our schools, and our neighborhoods, all to recognize. And so this is just an example of some ways that we're beginning to recognize that connection and build it into how we think about how we house people in our neighborhoods, how we go about transporting people through our neighborhoods, and how we engage our residents in planning for the future. On like one little like practical note, so just to leave you on this one too. So the next time you're around some kids, you want a full little magic trick. Tell them you can guess any color crayon and have them place it in your hand behind your back. While the hand's behind your back, scrape off a little bit of that crayon under your fingernail and bring that one hand in front of you and wave it in front of their head and say, you can read their brain and you can read their mind. And when you do that, you'll be able to see the color on your thumbnail, and you'll be able to tell them what the color is. So a little trick you can walk away with, if nothing else, from this little piece of it. So with that, I am going to turn it over back to Daisy and to Keith.
Awesome. Thank you, Barry. And thank you both so much for this wonderful information. We have Barry's contact information on here, but I don't know if there's any questions so far from all the wonderful information that has been shared. Feel free to type it in as the presentations are going on, and also let us know now. I actually had a question that any of you can speak to, in particular Barry, but if I want to start working with, you know, community developers, how do I get them to buy in? Or where do I go? Like, how do I even start that conversation if I don't even know where to find them or where to get them to listen to me? I don't know if you or anyone else has any lessons learned or tips.
So if you're talking about Community Development Corporation specifically, there's a really great association called the Massachusetts Association of Community Development Corporations, MACDC, and so they're a great starting point to tell you about essentially who might be working in your particular area. Often in certain cities and towns, there's also a community development department within the town, and so they're a really good point of access, not only what the municipality might have, but what might be available in the community. And then lastly, just because the recognition has been connected between community development and health, if you were just to go on Google and do community development and health, you actually find a great number of resources that could be provided.
Great, thank you. And again, if there's any questions, feel free to type them in as we go along. Thank you all so much for the great information so far. And we're going to queue up our next presenter, Kia McAndrew Davis, who's going to bring us through her presentation. So turn it over to you.
Yeah. And thank you, Maddie and Barry. I didn't know that I was going to have to follow a magic trick. As Daisy mentioned, my name is Kia McAndrew Davis, and I work in the Springfield Department of Health and Human Services. And I think I'm lucky to be on this webinar because Maddie and Barry did a really nice job of setting the context for public health and public health specifically in Massachusetts. And what I'd like to spend my 25 minutes doing today is talking about what that looks like at the local level. What does it mean in terms of the application in your municipality or your region? I manage two initiatives in Springfield, Massachusetts, which if you're not familiar with the geography of Massachusetts, it's all the way west, and we're a fairly large city of about 150,000 people. And on the left is the Mass in Motion grant, which actually was mentioned briefly earlier in terms of the state-funded initiative, which has been in Massachusetts since 2009. So it's been around for a while. You may have seen our logo. We're now at about 60-plus locations across the state of Massachusetts. And then on the right, what I'm going to delve a little more deeply into today is the second grant that I manage, which is called the 1422 grant. And if you don't know what that means, it's because someone at the Centers for Disease Control came up with that name. But it really means that state and local public health actions to prevent obesity, diabetes, and heart disease. Mass in Motion, really quickly, if you're not familiar with the program, like I said, it started in 2009, and it really came out of a report from the Centers for Disease Control that in the state of Massachusetts, we had about $1.8 billion of medical expenses in Massachusetts that were due to adult obesity. And Mass in Motion, I really like to think, if you're newer to the public health field, is more of a traditional grant. It's very small. It's about $40,000 to $60,000 per municipality. And the overarching goals are to increase access to physical activity and healthy food. So a couple of the images I've included here are some of the programs that might be in one of your communities and we have in Springfield. So we have community use programs when we look at, do you have public facilities that are open to the public, or do they close the public school playgrounds after dark and maybe the community can't access them? Or do you perhaps live in a food desert, which is a location that doesn't have a full-service grocery store? You can't walk and get healthy food, and you go to your bodega or your corner store and just take a moment to think about when you pump your gas and you go into the convenience store, what type of foods do you see on the shelves? And if you're lucky enough to see healthy foods, are they affordable or are they very expensive? Shifting gears into 1422 and really, again, grounding my narrative in Springfield, we had Mass in Motion since 2009, right? So focusing on physical activity and healthy eating programs all across the city. Very, very, very small grant. Then the Centers for Disease Control came through with this 1422 grant. And at the macro level, it was awarded to 22 states across the United States, Massachusetts being one of those 22, and then Springfield being one of the 4 locations across the state of Massachusetts. And really the focus of this grant is preventing obesity, diabetes, heart disease, and stroke, and reducing health disparities through community and health system intervention. So very small tagline, but really came about in response to these statistics, again, related to the Mass in Motion work, but versus that very small amount of programmatic funding, 1422 is a $440,000 per year grant that goes through September 2018. And I'm smiling as I talk about this because we're so lucky to take that funding and actually fund our partners in Springfield who have been doing a lot of this work over the years to take it to the next level. And I can't go to the next slide without focusing in Springfield. If you look quickly at some of these health statistics that are relevant to what this grant is focusing on, some are almost twice as high as the state average. Really quickly, diabetes 11.6% compared to 7.5% in Massachusetts. Overweight, 64.5% of women identifying as overweight versus 48.5% in the state of Massachusetts. And one easy way to think about this grant funding, because I know it can get confusing, especially if you don't live in this world, is thinking about the target population of who are we trying to serve. And really who that is individuals identifying as being pre-chronic disease. So for example, pre-diabetic or pre-hypertensive. And how can we enhance interventions and systems in our city that support people from stepping back from that precipice of being diagnosed with a chronic disease. I also like to include a visual because, again, it can be hard to kind of understand how this grant funding works. And this is a nice segue into the case study that I wanted to share with you today. But really the dual approach of 1422 is looking at individual healthy lifestyles and community systems that promote health. So over on the left, you're going to see that clinical component. So regardless of which field you work in that touches public health, I think when you think about the target population of a grant like 1422, of course there's going to be a clinical component. There's also going to be, and this is why I'm lucky to follow Barry, a built environment component, which is the fact of an individual going to their doctor and getting the clinical intervention services, but perhaps going home to their neighborhood and wanting to go for a walk and not feeling safe, or like the sidewalks are comfortable, or that they have a park that they can access, or maybe that they have a grocery store with affordable food. So really acknowledging the built environment is just as important as the clinical. Really briefly, I want to touch upon what this grant looks like in terms of the clinical piece, and then talk more about the built environment. So when we talk about promoting individual health through this grant, what does that actually look like? And what we've done is, because the grant is so highly funded through the Centers for Disease Control, is my office, the Springfield Department of Health, we contract with local agencies that are the content experts in these fields. So we work with community partners, our Community Health Center, which is Caring Health Center, and the YMCA, and they offer diabetes prevention programs in English and Spanish. These are year-long programs, so they're very intensive for individuals who are diagnosed with prediabetes. And because we're lucky enough, again, going back out to that macro level of thinking about the fact that this grant is in 22 states across the U.S., we're feeding our data into a national study that is now showing if you engage in this prediabetes class for a year, you will have cost avoidance, medical cost avoidance of over $2,000. We're also, we've hired 3 community health workers through the grant who speak multiple languages. And again, thinking about if you're someone who's trying to make the significant lifestyle changes that go along with prediabetes or prehypertension, your provider probably doesn't have more than 5 or 10 minutes to sit and talk with you. And the community health worker is the person who's going to sit, meet with you, and make community-based referrals. And what do I mean by that? I mean referrals to how do you sign up for food stamps? How do you access a free wellness site? How do you go to your local food bank? All probably not well versed in. And then having a referral system between all of these community resources to really get at that holistic, healthy lifestyle change from all sorts of avenues. The other piece, so again, going into promoting community health, what is the environment that we live in? A couple of the pieces that we're focusing on through this grant, through partners like the Office of Planning and Economic Development, Elder Affairs, the Western Massachusetts Food Bank. So really a lot of different people, like you all here on the webinar, we saw a lot of diverse sectors, getting back to Maddie's point of we are all working in public health. And some of the objectives for this specifically in Springfield are increasing community access to walking and exercise spaces, looking at healthy markets and affordable food along with food pantries, and then thinking about other food service venues like improving hospital nutrition standards. And a little aside, sometimes in public health and with grants like this, I think we feel like a jack of all trade and master of none, because we are tasked with looking at health and prevention from such a big perspective, and that's why it's so important to pull in the different sectors and different content experts to really make some progress. Quickly to take you through, I plugged in a case study here about wayfinding, and I wanted to just walk you through what do some of these initiatives really at the micro level look like at the local level. And so wayfinding, if you haven't heard of it before, I hadn't before last year, it can be defined as spatial problem solving. And really it's the idea of most of you, if you think critically about your city when you walk around, do you have signs that point you to what you can walk to, or do you have to navigate that yourself? How easy is your environment to walk, and how educated are you about what you can walk to? In Springfield, like I mentioned, we have about 150,000 people living in our city, and we have 17 neighborhoods. And the red circle is, I think, focused on the river, but it should be a little bit over to the right, focused on the Metro Center, which is where we decided to focus our wayfinding efforts. And we decided to focus on the Metro Center for a couple of reasons. One, you can see that geographically speaking, it's a really small neighborhood and it's really densely populated. In terms of health inequity, a couple of things from the 2009 census. In the Metro Center of Springfield, 20% of our population is unemployed compared to 8% in the city of Springfield. The percentage of people living below the federal poverty level is 45, so almost half of the Metro Center compared to 25% in the city of Springfield. And lastly, again, as we think about walkability, the percentage of houses that have access to a car, so maybe walking is not a choice, it's the only option of transportation, 48% of houses do not have access to a car in the Metro Center compared to 19%. The Metro Center is also a destination neighborhood. We have MGM Casino coming in a year and a half. We have very large employers like Mass Mutual, and we have a lot of educational and historical resources that we're really proud of, like our Dr. Seuss Museum. And then last but not least, I think in public health we like to say we should do things because it's the right thing to do, but we can't do them without citywide support, and we've been really lucky in this wayfinding initiative to have citywide support, and that's mostly because of the factors that I named previously. So we decided we wanted to do this wayfinding project, and it aligned with the goals of our grant. We decided we wanted to focus in the Metro Center, but then how do we actually come up with a game plan? And this is where we formed a steering committee with individuals from all sorts of backgrounds and knowledge expertise who had a stake in the game of trying to create a more walkable Metro Center. So you can see several city departments, you can see our regional planning agency, our central cultural district, which is also in the same geographical area, business representation, which is not always intuitive when you're thinking about public health, but so incredibly important to have at the table when you think about not only creating change, but creating sustainable change that the community is taking ownership of. And we also had consultation from the Department of Public Works, because if we're talking about planning and changing the roads and the environment, you better believe that we got to have our city engineers and the people that go out and work in the streets bought into the project from the beginning. We conducted 3 types of evaluation. 2 were pedestrian intercept surveys, and 1 was a formal walk audit. And I'm not going to call out all of the aggregate research, but we just wanted to get a sense of how accurate our understanding of the perception of downtown walkability was. And you can see a couple of the anecdotes, which, as Barry mentioned in his presentation, they're so meaningful when you're trying to share your program objectives and get buy-in at the beginning. So one individual said, I could tell you where the river was if I knew where I was. Or north, nobody operates that way in Springfield. We use landmarks to get around. And then the other type of evaluation we did was a walk audit. And we've actually conducted over 10 formal walk audits in Springfield over the years. But from a safety and planning perspective, if we're encouraging people to walk in our community, we do need to look at it from a critical perspective and say, are the sidewalks safe? Are the intersections safe? And the process that then happens is we get technical assistance from an organization called Walk Boston, which is a fantastic organization based here in Boston. They produce a report that then I'm able to share with department heads across the city of Springfield and talk about what type of changes we can make in terms of repainting the crosswalks, putting in new pedestrian lightings, and things that are going to make the actual physical environment more safe and walking friendly. We also realized that we didn't have a map, and we're not unique in Springfield, so we didn't feel too bad, but we were encouraging people to walk, and whether you live, work, or play in Springfield, we had no map that showed people how to get from point A to point B and all of the different types of resources that we had in the Metro Center. We've distributed over 3,000 of these maps in the last year, and there's also an economic benefit that helped us really win over a lot of support in our wayfinding initiative, which is that if you get more foot traffic by your local businesses, they're going to be happy and they're going to support your initiative. And what was happening was we have a handful failed in the. And if you came into our city for work or business and you wanted to get a bite to eat, the hotels were telling you to get in your car and drive to one of the cities 20 or 30 minutes away, when in fact we have really good restaurants half a mile, quarter of a mile, 0.10 miles away. We also had a really fun pilot, me climbing the pole that I put them up, and then my boss vetoed that. But we don't have a comprehensive wayfinding system in Springfield. We wanted to do a pilot because a permanent wayfinding system costs around $500,000 for a city like Springfield. So instead, we took $2,000, and there's two organizations, if you're interested in thinking about this in your community, that I would recommend looking at. One is Walk Boston and one is Walk Your City. So these signs are coroplast and they last for about a year. And another really important component, and I should caveat this case study with nothing in public health or really in life is linear. A lot of these steps happen concurrently, and capacity building was something that we consistently did throughout this work. And so when we put up these temporary wayfinding signs, we had a press event with our mayor, that's Mayor Sarno over there on the right, our CFO for the city, my boss, the commissioner and director of health, our principal planner, Scott Hansen, and then unfortunately I was sleeping. I think my eyes are closed in that, in that picture. But we did a press event educating people about what we were doing and why we were doing it. We did multiple newspaper articles and we did a TV interview. We also brought Gil Penalosa from Bogota, Colombia, who is, if you haven't heard of Gil, he's an international speaker on walkability. And we had planned to pay for Gil out of our 1422 funds, but when we proposed bringing Gil to Massachusetts and to Springfield specifically, the Department of Public Health actually offered to not only pay for Gil to come, but also to make it a statewide event. And this was a huge capacity building exercise that we did at the local level. Two things that Gil has done, and he speaks about internationally, are he's the father of ciclovia, which is the idea of shutting roads down to cars and opening them up to walkers and bikers. And this happens across the world. It's happened in New York City. It happens on a weekly, monthly, or yearly basis, depending on the place you're looking at. He's also the person who coined the term 880 cities, and it's a really good rule of thumb to think about when you think about your built environment and your community, which is the idea that if a road is safe and friendly for an 8-year-old and it's safe and friendly for an 80-year-old, it's probably going to be safe and friendly for everyone in between. The second part of what we did with Gil was we had him for 48 hours. We had a one-on-one meeting with our mayor. We did a walking and bus tour of our entire city. And then we had an interactive presentation where we had speakers such as the head of my Department of Health and Human Services, the mayor. We had the United States Department of Health and Human Services Region 1 Administrator, and then we had the head of our Department of Public Health do introductions. To say a lot of people with long titles and organizations. It's really just to compound the fact that it's very, very important to get buy-in from the top down. Shifting towards the end of my presentation and where we're at now with wayfinding is we are concluding our evaluation. We have our pilot signs up. We've done capacity building. We've done community engagement. And through 1422, the City of Springfield put out a request for proposal for design plans for that permanent wayfinding system that I mentioned before, which is a very, very expensive project, but something we are vested in. And we were very lucky to receive a response from a design firm called Applied Wayfinding, who has done design plans for cities like Rio. They're currently doing New York City. They most recently did Columbus before the Republican National Convention. And we've been partnering with them on taking all of our lessons learned through everything I talked about and designing a permanent plan for building a comprehensive wayfinding system in Springfield. What's next? We want to complete these design plans, which should be done in the next couple of months. And then we're going to conduct some evaluation to continue to stay engaged with the community to understand if our perspective is also the broader perspective. We're also working on securing funding, and Complete Streets was mentioned briefly, but this is something each municipality in the state of Massachusetts can apply for. Springfield applied last week. We're not sure if we've got it, but if you get the funding, it's $400,000 a year, and that would fund some of this, as well as we are in negotiations with MGM, who is going to be in the Metro Center, and so they have a vested interest as well in making the downtown a walkable environment. And just to share with you from the funding perspective, so thinking about Complete Streets and then thinking about MGM, it's really just about being creative and engaging different sectors in the conversation to make it successful. And then last but not least, really going back to the idea of capacity building is publicize, publicize, publicize. Sometimes you can feel like you're tooting your own horn, and sometimes my colleagues and I joke in different departments, I'll do a press event for them and they'll do one for my office. We have to share our work back with the community. In public health, it's really easy to become siloed and to sit at our desks and to do our work, and we're doing great, great work. But if you go out on the street and you talk to your average resident who maybe isn't working in the field, they might have no idea what wayfinding is, or they have no idea what 1422 is. And it's just really important to consistently educate, share, and ask for feedback. And speaking of feedback, that transitions into my last slide. I'm happy to answer any questions that may have come up throughout the presentation.
Excellent. Thank you, Kia, so much. And Barry and Maddie for your wonderful presentations. And tying it all together, we'll give a chance for people to marinate on all the information that was shared in the last hour or so, to type in any questions or comments as we have the experts live in the room that can help give some input. While you all are thinking, you know, I had a question in threading all the pieces that you all mentioned. I think overwhelmingly you all said that, you know, it's really important to get your message out there, right? Like to share what's going on, to share the importance of public health and policies you want to move forward, to use photo voice in creative ways to tell stories, and you in particular, like get out on the street and really talk to people. There are other ways that you've seen groups get creative about how they share their successes, the data that they found, or you know, any other lessons learned that you all have picked up on that could share, that you could share.
Well, Daisy, I'm not sure if this exactly answers your question, but I think it does, at least in part. I was thinking about an example that ties together the presentations, to your point, Kia, about Complete Streets, that I think is a nice sort of example of cross-sector work. A couple of years ago, actually some of Barry's colleagues at MEPC came up with this concept about this Complete Streets funding program. They actually borrowed a concept that had been built in energy efficiency around creating some funds for municipalities who met some basic criteria of their municipal energy efficiency activities. And it was sort of it was an incentive, right? It was a nice model because communities didn't have to do it. There was no mandates. Municipalities liked it. But by dangling a little bit of money, it pulled some municipalities along to put in place some better practices, and then provided funding to actually support them to do the work. So Barry's colleagues sort of took that concept and applied it to do something around Complete Streets. So it was a nice borrowing from another sector. But then we had a lot of policy work to do to actually put that into practice. So we worked very closely with MAPC and many others to lead a 2-year campaign to get the legislature to authorize this program. And we had to just mobilize tremendous support in order to get the legislature to do that. And it was really local stories that got them on board. And we almost never talked about public health during that campaign on purpose. We engaged a lot of mayors and municipal officials, And the things they cared about was quality of life and economic development. Quality of life and economic development. Every single mayor, every single town manager cares about that. And they did a lot of work working with the legislature to do that. We knew it was a good public health outcome, but we didn't really need to say it. We were successful there, and it actually needed the basically the sign-off of the governor and the Department of Transportation. And we went to them after the legislature acted, and they said, no, thank you, that's really nice, but you know, it's not a priority for us, so see you later. So another good thing I think we all do in public health, whether it's at the community level or the policy level, is we persevere. We don't take no for an answer. So we went back and we said, no, we really need this, and we mobilized mayors again, we mobilized community members again, and they said, all right, we're going to do $5 million in the first year. And we said, well, that's not really good enough. So we kept, you know, we kept pushing them. And then they said, well, we'll do $12.5 million over 2 years. And eventually they consented to do the full amount, which was $50 million over 5 years. And now that money is actually going out and hitting the ground in communities, actually paying for complete street infrastructure. So I think it's a great example of sort of multiple sectors working together, you know, sort of telling the story in the right way and persevering.
I guess I would just add to it too that I think often we think a lot of the changes that we might need to make in our community are going to take a really long time. But I think as Kia was showing with some of the testing of the wayfinding is there's a lot of really like quick, cheap things that we can do in our work, which does, one, it engages people because you're out there doing it and people want to know what the heck you're doing. But then two, you get to at least show people what that thing is that you're talking about as opposed to just seeing it on paper or hearing it talked about. So I think that's a great way to get more people engaged and really see what these changes could look like.
Well, thank you for that input. And, you know, personally speaking, who's been at the City Hall and talking to different legislators when we've shared work on our tobacco prevention work, and we walked around with young people and folks who are out in the community seeing the effects, personal stories definitely are the ones that the legislators really care about because they want to hear what their constituents really, what's on their mind and what they're thinking about and what they can do. And you know, in essence, that's also why they're in office, because of local folks who care to get out and vote, and if possible, if they are able to as well. So thank you for sharing that. I don't know if there's any other questions that folks have for our presenters here. We went from Maddie's presentation to really talking about the history and how public health has evolved and kind of some big picture information, with Barry really talking about the built environment perspective and how we're working with that field, and many examples with that. And Kia kind of brought it home with some Springfield examples and the wayfinding initiative. So really a great kind of succinct way to really frame public health and how, you know, we're biased here, but how important and beneficial it is for us to spend our efforts and energy on it.
So just to add to that, too, I think so. Often, kind of working in the planning field, in the field that doesn't necessarily always consider public health, although we have actually a history that's quite connected. I think sometimes even moving beyond saying public health to just saying people, because really, unfortunately, I think a lot of the work that has been done in the past, whether it's our interstate highway system, whether some of the issues you see related to environmental justice, there wasn't actually a lot of thought given to really who we're doing it for and what the outcome we desire is. And so making that connection, this is where I have to say thanks to people like Maddie and Kia, coming from a public health perspective more strongly and being steeped in it, just to bring that back into the center lens of that it's really for people, it's for our neighbor, for our friend, our family, and it's such a big part of this.
Well, thank you, you three, for a wonderful presentation. Lots of great information shared, a lot of things that I know I personally learned, and hopefully you all did as well. We have shared their contact information, and will again in another slide, but feel free to type in any more questions that you have, like one that just came in now before I start wrapping up. But thank you to have sent this in. So there's a question on wondering how you decide which initiatives to work on. So discussing unemployment rate and poverty and wayfinding. So Kia, you want to give some
Yeah,
on that?
that's such a good question, and I think we all live with that on a day-to-day basis, which is It's kind of the chicken or the egg question, which is, yes, I am responsible to reporting back to the Department of Public Health and then the Centers for Disease Control on the specific objectives of the 2 grants that I work on, but we would not have been awarded those grants if we had not sort of shown ourselves as ready and willing to work on those specific initiatives. And just rereading my question. So yeah, I think it's a little bit of both, and I think the reason I showed Mass in Motion and 1422, which are similar objectives but very different in the way they operate, is kind of 2 ends of the spectrum, which is not to say those are the only grants out there, but you have a grant like Mass in Motion, which is incredibly broad, and then you have a grant like 1422, which is incredibly prescriptive, and we're lucky in Springfield to have both of those, which isn't the case in every municipality.
Yeah.
And I was going to add to it too. So a tool if people want to explore it is a tool of health impact assessment. One of the great parts of that is that often we know there might be a connection. So we know there's a connection, say, for example, between transportation and health. But how you're going to look at it within the particular context of a decision, within that tool, you actually go through a process called scoping. And so essentially working with residents and working with data and literature they have access to, that kind of helps identify what are those priorities you're going to focus on. Is it whether people can bike and walk? Is it whether people are really kind of thinking about safety and crash issues? So I think actually having a scoping process that links to and bring in health considerations is a really important part. It can kind of help service those issues.
If I could add to that too, I think in addition to scoping is figuring out what the community feels is an important need right now, where the energy should go, even if that maybe directly conflicts with what data says, right? So we got to listen to the people, but I think, Jacqueline, you pose a good question, and it's a conundrum, right? So how do we get the work done, especially if it takes a lot of people time, which equals money, as well as actually needing real resources to get it done? I have worked and still continue to work with many coalitions around the state and in other states who are really relying a lot on volunteers to really get this work done, who care intentionally about it. So not to say that that's the only way to do it, but you know, it's listening to the community, figuring out what is needed, talking to city officials and community development corporations, any multi-sector partners you can get to the table to pay attention to this. So really tying in what all the presenters have said. And when in doubt, really just listening to your community and hitting the ground running to ensure that you are addressing their needs. And at some point, I have seen, and it is possible, to get those issues to gain some traction and figure out kind of where to go there. But it is a real limitation if you are only relying on funding to help fund something that you're really excited about. If you're lucky, that comes up, but that's not always the case. So there are creative ways that people figure out how to really just address real community needs. But definitely the multi-sector partnership, which we're going to have a webinar on that to really support people to think about how to create those partnerships and build on them. But just some additional thoughts on that, as well as we have some other questions here that I wanted to name, which is, what can we do from a public health perspective to help with the mental health issues in our youth? So that's one question from Judy. Thank you for that. And do you have a high number in resident participation in your program? So I guess it depends on who wants to take that question.
I can start with the second question about resident participation, and I should have said to Jackie's first question, we do have in Springfield, we have a Springfield Wellness Leadership Council, which is comprised of people who live, work, and play in Springfield from all sorts of sectors of the city, and we share back with them. This is what we're absolutely tasked to do as the grant recipients, but what's happening here on the ground, and how do we kind of marry those two to the best of our ability. And then to ask the other question about resident engagement, it's always a tricky one, and we always try to do it. I don't say that we could always do it better, but in things like, for example, the wayfinding, if we're going to do a walk audit, we go out and we invite residents, and we do that usually through the avenue of The intervention is usually looking at a specific neighborhood, and so we'll go to the community resources that have leadership in that neighborhood. So that might be a faith-based organization, it might be a senior center, it might be a school, and starting from there and getting those organizations that are already there and embedded in the community to recruit for us to get participation from residents in whichever initiative we're working on.
For the youth and mental health piece too, I'm not going to pretend that I had an answer for that, but I think a practice that you could look at too is earlier in the presentation I showed a pathway diagram that we used for health impact assessment, and I think if you were to look online, you may find similar things, or even kind of be able to develop yourself. But actually beginning to kind of ask those questions of why in that particular place might you have a youth mental health issue, and beginning to work upstream about what's doing it, because obviously there's a programmatic response. As Maddie mentioned, you want to know someone's there to help kind of treat somebody if they have experiencing mental health issues. But often there's a lot of things that have preceded that person getting to that point, especially if it's not something that somebody's kind of genetically born with. And so I think beginning to think in your own place and in the work that you do, how you can begin to move further upstream, that kind of connects back to what Kia has been saying too, like in terms of who else you can bring into the fold and what else you can connect to. So as a practice, I really encourage thinking about it that way systematically, to think about who are your other partners and really what are some of the kind of causal or associated pieces that are driving it.
I think Barry's point on this is a good one, and I'm not a mental health expert at all, but I would say in terms of the public health approach, some of it is the questions you ask about what are the factors that are causing poor mental health outcomes, what happens when you look upstream. And I think one of the other questions is who's being impacted, what are the differential impacts, and actually looking at the data if it's available, or just sort of anecdotal evidence in your community. How does it break down by race and ethnicity? How does it break down by income? How does it break down by neighborhood within your city, like Kia talked about? And you're probably going to find that certain populations are getting better access to treatment. Certain populations are living in conditions that lead to poor mental health outcomes. Certain populations might be more likely to end up in the criminal justice system than in treatment, and trying to identify what that data shows up to target our interventions to address those inequities.
Thank you all for all those great ads. And if I could add a little bit on the youth mental health piece, I do a lot of youth development work across the state and the country. I would say, and you're probably already doing this, Judy, but sometimes what happens is we got to pay attention to what language people are using. So even though it's important from a public health perspective to think about the whole person, oftentimes things are parceled out by issues, or like whatever, like substance abuse in particular. Like there's an opioid epidemic happening right now in the state. So they may be talking about mental health, but within that framework. The same thing in most school or after school time, out of school time programs, they're talking about trauma-informed services, which is leading with the trauma, aka the issue, but ultimately what they're trying to arrive to is healthy mental health for young people. So it's really paying attention to those conversations, being in those conversations, especially to look out for whenever public health is not really being inserted or talked about in those settings. So I've learned over the years is to just really listen to the language people are using. Oftentimes they are saying the same things we are, but maybe framing it in a different way. So I think, those are some other kind of strategies I would add in thinking about that. And, I think it's important to keep coming back to public health approach to any of these issues that we're working on. Who's at the table, who needs to be at the table? Are we looking at data and information that we need to pay attention to, and then what do we do, right? And then how do we get there, and many other steps after that. But thank you all for your great questions here. We have one more, and then we're going to start sliding into closing. What are major data sources that you use in determining the interventions? Is it largely CDC data or national sources? Anybody want to take that?
So I'll quickly give a shout out. Probably my favorite is called What Works for Health, and it's through the Robert Wood Johnson County Health Rankings. Just a fantastic source where you can look by type of intervention, issue, population group. Just type in a keyword and it'll come back to you with essentially where the evidence is on certain interventions. And it's really important to know essentially what evidence there is behind some of these, and really important on the other end to know which has actually been shown not to work, because sometimes you can continue to go down a road if that hasn't been evaluated, or if it has evaluated and it hasn't been. So What Works for Health.
I was just going to mention there are some really good CDC data sources, behavioral risk factor surveillance system, for instance, that is a survey that has really good data on a lot of public health issues. But also just to remind folks that sometimes there's not a good data source on a particular issue or on a particular population. And sometimes the data has to be talking to people, asking community residents, or asking leaders of community organizations, asking community health workers. And I think, you know, in public health, you know, we want to follow the data and be true to the data, but we also want to act, and sometimes we need to use the data that we have available to make the best choices and you know, drive the best interventions, even if there isn't a really great national data source available.
Awesome. And Judy, will get that answer to you all, and all these resources that have been shared, we will include in the follow-up email for you all so you can have and carry with you, along with the recording of today's webinar and the PowerPoint slides. And it was a great segue, actually, for some upcoming free trainings and webinars that we have. We have a Using Data Effectively webinar coming up in October 26th. We're going to have a wonderful presenter from the Department of Public Health who's going to present, you know, what is effective data? How do I tell a story from the data that I'm collecting, or really know where to look, not necessarily in websites specifically, but in terms of what's happening in my community. So that's a webinar that's already open now, and we will be marketing that soon. So if you're not on our newsletter, please add yourself to it. We also have some additional webinars coming up in November. How to identify multi-sector partners. That's coming up November 17th. And there's 2 in-person trainings that we're going to be doing: coalition capacity building and infrastructure, and then coalition sustainability and resource planning will be offered on the same day. We are planning to do it in the Berkshires area. We will share more information soon on a specific location for folks to sign up. But again, you can find all that info and any other updates on our website, hrainstitute.org. And again, I want to thank our wonderful presenters today, Maddie, Barry, and Kia, for all the great work you've done and all the information you shared. It's really has been a great learning experience. I also like to thank the Massachusetts Department of Public Health for making this wonderful resource free for folks like you to take advantage of and really take with you and share it in your community. There are many ways to be in touch with us. There's our email, our website, our Twitter handle, and we're on LinkedIn. Again, add yourself to our email list so that you can get updates right as they come up. And again, I'd like to plug the event that Maddie shared with us for his organization, Massachusetts Public Health Association. Their annual meeting is happening November 16th. Awesome. So it has a racial justice focus, some great presenters or speakers that day. So please check it out. And we'll share more in our follow-up email. And please, please fill out the survey for today's webinar. We'd love to hear your feedback. And we thank you for all that you do, and thank you for joining us this afternoon.
Thanks to Daisy and Kelly, too.
Yeah, thank you.